welcome.
Welcome.
Just give everyone a few minutes to log on.
I'm just waiting for, I'm just looking at the numbers.
Excellent. So for right now, I'm going to pause the recording and then restart it again.
Sure.
Okay? So that when we have the recording, will be easier to cut this welcome part. So just, let me know when you're ready. Thanks.
Welcome to our ACCOUNT4COVID webinar. This is the third for our initiative. My name is Rachel Gondo Magama, and I work with the Public Service Accountability Monitor based at Rhodes University in South Africa. And PSAM is a member of the ACCOUNT4COVID initiative. The initiative is convened by 7 organizations: Accountability Lab, AfroLeadership, BudgIT, Code or Follow the Money Africa, CRECO, Global Integrity, and as I said before, PSAM. And the initiative's goal through its webinar series is to bring together actors across the region to analyze the impact of COVID-19 on fiscal governance and exchange ideas and lessons for possible strategies to improve transparency, accountability, and participation. So I've introduced myself, and I've also introduced the initiative. In the chat, we've asked you to introduce yourself, but also we're going to, please do tell us your name, where you're from, also respond to the poll and tell us which continent you're calling from, or you're joining the webinar from. But also use the chat feature to actually tell us who you are, your name, as well as your institution. The poll is up now, so if you can tell us where you're from, we'll be able to see the results shortly. Great, thank you for the people who've already indicated in the chat. Thank you, Zukiswa and Veronica. Zukiswa from South Africa, Veronica from the US, welcome.
Okay. And I'm sharing the results of the poll right now, if you can see them.
Thank you. And we have 57% coming in from Africa, and a few from North America and South America. Greetings. Thank you, everyone. Please do continue to introduce yourself in the chat feature. For our conversation to flow smoothly, if you have any questions, please do use the Q&A box on your Zoom toolbar. You can pose a question to the panelists using that box. You can also post a question in the chat, because we'll be able to man both fronts. You can also use the chat feature to get to know who else is on the call, and also to access any resources that we will also share as we discuss this during the meeting. As I said before, this is the third webinar, and it's entitled Overcoming Vaccine Hesitancy. And we will explore the underlying causes fueling vaccine misinformation and why it has been effective in creating vaccine hesitancy in Africa. It will explore the various ways in which civic actors can meaningfully contribute towards vaccine delivery efforts. For example, and particularly, we'll discuss the kinds of financial investments and interventions governments should be making into strategies and programs that promote vaccine uptake or promote the uptake of vaccines in the continent. And of course, our conversation is guided by research from Amref Health Africa, and the COVID Transparency Accountability Project, CTAP. On the panel today, I have Professor Joachim Osor, and he's the Vice Chancellor of Amref International University. He's a medical doctor, a public health specialist, and an expert in sexual and reproductive health. He's widely published and has done a number of studies in vaccine hesitancy in Kenya. Our second panelist is Ayomide Ladipo from BudgIT. And Ayo is a writer and a development advocate, and she's a graduate from the University of Lagos in Nigeria, and she has worked in the non-profit sector in different capacities. With Fair Life Africa Foundation, Women at Risk International Foundation, just to name a few. She's also a published writer and has strengths in content creation and creative writing. Currently, she's the producer and she's a content producer and storyteller at BudgIT. Yes. So our first, in terms of the format, we will have Prof. Yosur present, and after his presentation, we'll break and take a few questions and allow him to respond to a few questions, and then we will have Ayo's presentation. Over to you, Prof.
Thank you very much, and a great pleasure to have been invited to be in this panel. As you've heard, I come from Amref International University, which is part of Amref Health Africa. And let's just move to the next slide. I think it's important to start by making clear some definitions. When we talk about vaccine hesitancy, we are talking about basically two things: refusal to accept a vaccine or a postponement of acceptance of a vaccine for various reasons when the vaccine is already available. And so you have a situation where you can have very many people accessing and accepting a vaccine, and you have a high demand. Some may even be unsure whether they want it, but they accept it. And then on the extreme end, you may have very low demand and refusal to have the vaccine. And some refuse because they have reasons, others refuse, but they may not even have a reason. And then in between, you get all manner of levels of acceptance. So when a vaccine is available, a lot of things can happen between high demand and low demand. And that is really what vaccine hesitancy is about. Next slide. So I know the core issue here in this meeting is about accountability, accountability for resources, accountability for the decisions we make in the health sector and in governance and all that. And one thing I wanted to say is that I know everyone now is really talking about vaccine equity and Africa not being able to get vaccines because the North has ordered for all the vaccines. And so even if you ordered, you paid for it, you won't get it because the manufacturers cannot cope with the demand. And so there's a lot of discussion around the world on vaccine equity and the need to make vaccines available in Africa and other developing countries. However, what we know is that if we got all the vaccines that we need in Africa today, we will be surprised at how many people actually will accept them. We have seen in DR Congo just today, Democratic Republic of Congo has given away 1 million doses of vaccines which they had because those vaccines are about to expire. And the population there is not accepting them. We also saw South Sudan do the same recently, and we saw Malawi actually banning the vaccines which had expired. And so, although we are really talking much about vaccine equity and how rich countries should make vaccines available for the southern countries, the truth is that if those vaccines were available today, they wouldn't be taken as much as we think they would be taken. And the reason is because right now, all the funding that we have is going towards the purchase of vaccines, more or less, and sometimes testing for COVID. And very little money is going towards preparing the health system to be able to deliver the vaccine in an equitable way. And worse still, almost no money is going towards preparing communities to be ready to accept the vaccine. I want to give you an example. Before we launch any new vaccine, for example, I think one of the latest vaccines has been the one for preventing cervical cancer. There was a lot of money put before the vaccine was introduced into preparing communities. There was a lot of community education. There was a lot of media publicity about the vaccine. And so when the vaccine came, everyone was prepared for it. They knew about it. They had the right facts. Our studies in Africa show that one of the greatest reasons why people are saying no to the COVID vaccine is because they do not have information. And when they do not have information, they don't want to risk having a vaccine they know nothing about. And many governments are not putting any money into community education, community sensitization on the vaccine. A lot of people are getting information from social media. Most of it is wrong information, distorted information, and scientific information. And the anti-vax community have taken advantage of this. They know where the weaknesses are, and they have really, loaded their messages into communities. And right now, negativism, the negativity around the COVID vaccine is very high in Africa. So what we are saying is putting funds in vaccines is okay, but without funds to prepare the health system and without funds to support community preparedness for this vaccine, what we are working towards is really hesitancy. Yeah, so there will be a lot of hesitancy unless we change the current funding mechanisms for the COVID vaccine. Next slide. But beyond funding the community interventions, the community education interventions, political will and governance around COVID and COVID vaccine are very important. One reason why most of the communities in Africa do not want the COVID vaccine is because their leaders started by saying something negative about it. Many leaders were not ready to get vaccinated. And they said something negative, that it was not a good thing. And so what people say is, if it is bad for my leader, then it is not good for me too. And so the political leaders have played some role in the current levels of hesitancy that we are seeing. But in addition to political leaders, other leaders, including church leaders, have also once in a while made statements which made people think that COVID vaccine is the wrong thing for them. Beyond just individual behavior, we have also some institutionalized decision-making, which was not good. Sometimes people made decisions which were not scientifically backed, and they had wrong consequences. And sometimes they actually also did not use the funds for COVID well. I remember in Malawi, for example, the president has had to sack some people for misusing funds meant for COVID. In Kenya, we had a big scandal around funds meant for COVID, even donations for COVID, the PPEs and so on, were not correct, used well. People sold them off and pocketed the money. And so because of the governance issues around COVID, people no longer trust their governments. They no longer trust what the government says. And when the government says that COVID vaccine is good for you, they take it as one of the other ways, the other ploys to reap them of their money. And that is a big problem now. When people cannot trust the Ministry of Health and what the Ministry of Health says, you end up with problems. We saw this during Ebola, when people did not listen to their governments. The disease just became, like a bushfire. And so it is happening with COVID now. It is happening with the vaccine because people no longer trust their government. When they say lockdown, people don't want to lock down. When they say take the vaccine, they don't want to take the vaccine because they don't trust the government. They don't believe the government means well for them. And so governance issues are really, really fueling hesitancy. Next slide. But there are other peculiarities in Africa that are also fueling hesitancy. Our studies show that most of the people who are hesitant to the COVID vaccine, as we've said, they lack information, they have wrong information, and they do not trust science. And one thing about this group of people is that most of them are poor, they are uneducated. And interestingly, women tend to be more hesitant than men. And so it is becoming a gender issue. It is becoming a health equity issue. The people who have traditionally been left behind by other health services seem also to be getting left behind now when it comes to COVID vaccine and COVID intervention. And a lot more needs to be done to target this group, to message towards this group. Otherwise, COVID is going to become the poor man's disease, not just in between countries, but also in countries, because there are some people in Africa who know and who can afford. Some have even flown off to rich countries to get the other vaccines. And yet here, we have very poor people who are highly hesitant. Next slide. So the big question then is, when will we know that things are changing for the better? I think one indicator that is very important, we need to continue looking towards, is when community engagement for vaccination is funded more than when procurement of vaccines. Well, so let me put it this way. We do need money to buy COVID vaccine. But you can judge if things are happening well if the money for buying the vaccines is much, much less than the money for community sensitization. Right now, we have very little money to buy vaccines, and we have no money to do community sensitization in many countries. And that will not eliminate hesitancy. We will not achieve the vaccination rates that are necessary for herd immunity, and we are being left behind as a continent in access to the vaccine, and even more the poor people living in Africa. So we hope that at a certain point, there will be more money going towards sensitizing communities. There will be more money going towards targeting the people who have traditionally been left behind than money going towards buying the vaccines. If that change happens, then we can expect vaccine hesitancy also to go down. I think I'll stop there. Thank you.
Thank you, Prof. You raised some very important points there around the fact that even though our current focus is on vaccine equity and the need to make vaccines accessible on the continent, there's definitely an area that needs to be looked into in terms of the preparedness of the health systems themselves to receive these vaccines and actually maintain them, and then actually have the recipients take up these vaccines. So there's an area that you feel may be neglected. And thank you for those very important points. As I said earlier, we are making room for questions directed to Prof. Yassir. And in the chat, if you've noticed, copies of the Amref University research, where Prof is highlighting some of the findings, where he's talking about some of the findings from this research. They will be shared with the webinar recording to those who registered for the webinar. I'm just checking if there are no questions as of yet. You are welcome to post your questions in the question and answer box, and also in the chat feature. Do feel free to ask your questions. Yeah, and you can also raise your hand. Sorry about that. You can also raise your hand if you would actually want to ask your question. There's a question. Okay, I think that's there are comments that have come in, Prof, for you. So there's also thank you, Prof, for stressing the importance of the governance issues. Governance failure impacts the way in which communities react to the vaccination process. And I think in your presentation, you highlighted an issue around how this is affecting the extent to which the public can trust what the government says. So maybe if I can write on this contribution and ask a question to you, Prof, in what ways could the public trust, the government counter misinformation to enhance public trust?
Yeah, so it is very important that the decisions that governments make, two things. One, that they are scientific in nature. They are based on science. And secondly, that they are contextualized. What has happened in Africa is we cut and paste. What happened in China, we cut and paste it in Africa. What happened in the US, we cut and paste. Let me give you an example. So you tell a nomadic community that we are locking you down, you can't leave your house. They have cows to go and feed. How do the cows feed? You tell market women, because we do not have delivery services for food, and you tell market women and men that you can no longer sell in the market. And then where do you get food? Because there are no other avenues for selling food. So we cut and paste. Instead of making the market safe, we close the market. Instead of finding ways of telling a nomadic community how to graze their cows safely, we want to lock them down. And so having scientifically based decisions and contextualizing them is what will bring trust in the communities in Africa. And that is currently lacking.
Thank you so much for that, Prof. I think we will jump directly into Ayo's presentation.
There is one more question.
There's one more question. Okay, great. Okay, so the question, Prof, what are your thoughts on the distinction between hesitancy and the hoarding/shortages, and what has been referred to by many, including the World Health Organization, as vaccine apartheid? Which would you characterize as the greater threat, hesitancy or the very lack of the vaccines in the first instance?
Both of them. I would give them 50% each. Look at the story of DR Congo. Why are they giving away 1 million doses of vaccines when they have none? People don't want to have the vaccine. So you can have all the vaccines you want in Africa, but without having the communities ready to be vaccinated, it's it's not going to create any impact. It's a fruitless action. So as much as we want the vaccines in Africa, and it is very important that we have vaccines in Africa, and I think it is wrong for people to hoard vaccines, we also do need to prepare communities in Africa to accept the vaccine. Otherwise, there is going to be a lot of wastage, like what we've seen in Malawi. We'll get the vaccines, they will expire on us, we will have lost money. And I think that's not helpful at all.
So in terms of preparing communities to receive the vaccine, and I saw in your presentation you put emphasis on the fact that government needs to focus more investment or direct more investment towards civic education for communities on the vaccines and how they can play, how they're useful in combating COVID-19. Another question for you, Prof, is what can civil society do, especially coalitions such as ACCOUNT4COVID? What can they do about vaccine information, misinformation, and hesitancy?
We need, I would say, solidarity across Africa. We need to agree that we will only accept what is scientific, that we will not allow our governments to make unscientific decisions around COVID. We also need to agree that we will no longer tolerate misuse of funds meant to save lives, that those who are in government and in other positions of authority and are misusing these funds and causing deaths should not be tolerated among us. We also need to, talk about budgeting and influence how these budgets are allocated. I think our voices need to be heard, that if we do not have enough money to sensitize communities, we are basically also promoting vaccine apartheid, because it's only those who are privileged, those who know about it, those who read newspapers and listen to BBC and CNN, those are the ones who will go for the vaccine. So unless we proactively also take care of each other, the Ubuntu spirit in Africa, that unless you are safe, I'm also not safe as a brother. If we don't do that and we don't put money on doing that we are also promoting vaccine apartheid among us. So these are things that we need to talk about as civil society, because if we don't, nobody else will. And what you will see, governments tend to only give the good story, not the bad one. We need to give the bad story.
Okay, thank you, Prof. And I think as a follow-up to what you've just said, are there any low, middle income countries that are getting this balance between the civic education aspect and vaccine procurement right?
Well, so far, I don't think I've seen one country doing this very well. We are told that Morocco has very high vaccination rates. I'm not sure, but Morocco being part of the Arab world, maybe the culture and all that is also different. But in the sub-Saharan African countries, I think we are not doing well at all on this. I don't have an example to give.
Thank you for that. That's very worrying, though. Thank you for the very, very useful questions. There's a question for us. Professor in the chat says, why are women included in that list of population that are being left out? Could you please explain more about this?
Yes, so everywhere in sub-Saharan Africa, men are taking vaccines more than women. If you go to any country, you will find the people who have had the vaccine, maybe 60, 70% are men, and then the rest are women. We have done some studies to find out why this is the case. And one thing we have found is that women tend to get information more from the social media than men, who tend to get information more from radio and TV. And then there is also a perception that COVID affects men more than women. Of course, scientifically, we know that could be true. But so the result of all this is because social media tends to have more unregulated information, women are tending more to have these vaccine hesitant, anti-vax messages more than men, and they are tending more to be hesitant. But at the same time, this whole story of men more affected makes women feel that they are safer, that they may not suffer even if they get COVID. That is what we know right now. There could be other things. We know that decision-making around health in Africa, in many communities, women in masculine communities, most of the time women need permission even to go for the vaccine. There are also issues around transportation, centers where vaccines are offered, and in communities where women do not have resources and men have resources, it is easier for a man to get themselves to the vaccination center than women. So there are all these issues that are making women be left behind when it comes to vaccination.
Thank you for adding some more flesh to that. I see there are no more questions. If we can move to Ayo's presentation.
Yes.
Ayo, over to you. Your slides will be up in a second.
They're up.
Yes.
Hi, I was talking there and I didn't unmute myself. Good day, everyone. Am I audible enough?
Yes, you are.
Okay, great. So thank you for your session, Prof. That was quite enlightening, and also one of the discoveries we made during our research. So the CTAP research that this presentation is focused on was based on both the fiscal capability to procure vaccines and also vaccine hesitancy in Africa. So we didn't just look at the capacity of the government to actually buy and produce vaccines. We also looked at the other end. So when you're buying and producing vaccines, just like Prof said, who is taking them? So I will be talking about the vaccine financing and production in Africa. So a quick intro on the CTAP project. So the CTAP is the COVID-19 Transparency and Accountability Project in Africa. And basically what the project sets out to do was, because definitely it's still ongoing, the pandemic is not over, is to cover all the aspects of COVID-19, both the financing, every aspect of COVID-19 in selected countries, tracking resources from the public sector, private, the donors, and also do research on how these things can be better. Definitely nobody has experience from a pandemic. So I think these resources, that one of the major reasons why the CTAP project is here is as a guide, and is as a guide for us now, and a guide for, we don't pray for another pandemic, but at least it will serve as a guide for if something like that ever happens again. So the CTAP project covers Africa, but we are focused on 7 countries to major on. We have stronger interest in Nigeria, Sierra Leone, Liberia, Ghana, Malawi, Cameroon, and Kenya. So one of the things, one of the resources we have is this research that we did on the fiscal capabilities and vaccination hesitancy in Africa. Next slide, please. So currently where we are in vaccination, though I think a lot of us are talking about vaccination. Are we even actually vaccinating? And I think that that's one of the things Prof has handled. But let us also look at the economic aspects of it. So in Africa, currently, only about 2 doses of COVID-19 vaccine have been administered per 100 people, compared with an average of 68 doses per 100 in high-income countries. And less than 1% of Africa's population has been fully vaccinated. So another issue is that when we are looking at this vaccination, a lot of the vaccines we are getting are from the donor, I want to use the word donor giving initiative. So COVAX is one of them, and COVAX has allocated about 600 million doses to Africa, but they are coming in batches. So, and COVAX's numbers can only vaccinate less than 40% of the population. So what we are assuming here, based on this research, is that if the whole of Africa were open to vaccination, let's say everybody wakes up tomorrow and they're like, okay, we would actually love to be vaccinated. Do African countries actually have the capacity to vaccinate? So while we should focus resources on combating vaccine hesitancy, when we now, because okay, we want to, when we are doing vaccine hesitancy education and conversion, we want to tell them that, okay, yes, this was vaccines, take them. So when they now successfully say, okay, now we are ready to take them, do we have the vaccines that they can actually take? Next slide, please. So we are going to look at just a few points from our fiscal capabilities. So before we even go to our vaccine fiscal capability, what are the health budgets of this country? These countries, the focus countries. So in all the focus countries, in 2020, none of them reached the 15% benchmark. So your total health budget, your total budget for the year is about, let's say, $100 million, and you have less than $15 million going into health. So what is actually, it's actually ironic, because I think, not being too technical, because I think the essence of why everybody is actually alive to even talk about budgeting, vaccine and everything is health. If everybody does, okay, so we saw that play out when the pandemic just started and the world halted. So if there is no, if your population is not healthy, how can you even have economic growth? But it seems our governments do not actually see a line drawn in between this. So currently we these figures show a health budget allocation, and we can see all the range, and none of them are up to 15%. So even on a normal level, do our health budget even serve us? And this is how we see that all the issues are interconnected. Prof mentioned about how citizens distrust government. And that is one of the reasons why they won't take the vaccine. Now, citizens distrust government because the government has not shown to be for their well-being. So look at these figures now. So these figures are figures there, but they are actually lives being impacted. So for every low allocation, there are people that are dying from low quality healthcare in different capacities. So when the people see that the government has shown over and over again that they do not have their best interests at heart, why would they think that the vaccine, you also have their best interests at heart for the vaccine? So all these issues are also interconnected. And next slide, please. So this table shows, if you're looking at this table very well, this table shows our capacity to have vaccination costs. So if each of these focus countries were to fully were to vaccinate 70% of their population, what is the percentage it would take out of their health budget? If you look at a country like Nigeria, the cost to vaccinate 70% of the population is like far more higher than the health budget. So we can see here that these countries do not have the capacity to actually vaccinate their citizens. So now it's like a two-edged sword. We are saying that we want these people to take vaccines. And we are also asking that, do you actually have the capacity to produce vaccines? Now, this now takes us to where we start doing, I use the Nigerian word beggy for vaccines. So then we start asking, then there's another thing that we also do, and be like, oh, developed countries are purchasing more vaccines than they need. They should donate some to African countries. They should do this, they should, okay, fine. You can tell people what they should do on moral level, but you are a continent and you are countries of your, why are you not also capable of also purchasing and developing your countries enough to buy your own vaccines? So now, even the COVAX, currently, the vaccines that we have are the vaccines that are coming from the COVAX initiative, the vaccines that majority of African countries have. So that also says another thing, that what are African countries actually doing? So now we are just talking about COVID-19 today. What if another pandemic comes up tomorrow? And we like to talk about how lucky we have with this COVID-19. It didn't affect African countries as much. What if the next pandemic is going to affect African countries as much? How are we going to actually deal with it? So if we look at, there's the revenue on the table. If you can see the slide, there's the revenue. There's the estimated cost to vaccinate 70% of the population. There's vaccination cost as percentage of public revenues, health budgets, then projected vaccination cost as a percentage of health budget. So even the COVAX doses can only cover everything here is less than 10%. But let's say that by the time all the doses they've allocated to us come up, we'll be able to vaccinate 20% of our population. What about the remaining 80%? So is it the countries that do not have money to buy vaccines that will have money to actually combat vaccine hesitancy? So we have to look at that in both ways. So also in this slide, currently there are 8 vaccine manufacturing companies with existing or potential vaccine manufacturing capacities identified in Africa. Only one, I'm putting emphasis on one, only one of these companies exports a WHO pre-qualified vaccine. So now, if we look at these figures, we're actually in big trouble. And I want us to note that this is also one of the reasons fueling distrust. If African countries do not have vaccines coming out of the continent that are produced in the continent. Now, a lot of people, if we look at one of the reasons, when we did our research, a lot of the reasons why people were giving, why they were not taking the vaccines, was because they felt it is an Oyinbo vaccine. Oyinbo is white man, Mzungu. It's coming from the West, so they do not trust it. Imagine if we had vaccines coming in from Africa. That particular reason would have been struck out. So we do not have vaccines coming from from Africa at all. All of them are produced by the West. Of course, they'll be like, we don't trust these people. Yeah, we don't trust them. They have colonized us, but we don't trust them too. Yeah. So that's also another reason. So we can see how, even though this looks like a financial capacity, everything intertwines: financial capability and the hesitancy and also the thinking behind it. Everything intertwines. Next slide, please. So yes, so we go into the economic preparedness of countries before for pandemics. So when this economic preparedness checked out about, I think, about 18 or 19 indicators to measure the economic preparedness of countries to tackle pandemics. So let me find the indicators here. So some of the indicators are the national legislation, food safety, immunization, reporting, laboratory system, emergency response operations, etc. So when we, the economic preparedness was by some WHO, it is actually conducted by some WHO volunteers in each country to check their score. And their score ranges, as it shows on the slide, their score ranges between 0 to 39, 40 to 79, 80 to 100. So I think if they share the research document in the link, we can actually get full info on that. So no African country has a JEE ready score within the range of 80 to 100. And so none of the countries is said to be better prepared for an epidemic. But what I would also like to note from that, from this economic preparedness was that to a large extent, West African countries were better prepared for an epidemic because of the Ebola situation. So we had countries who have battled Ebola, countries who had battled Ebola already had, because Ebola is also a virus somehow like COVID-19 that it involves isolation, contact tracing, emergency. So those institutions and framework were on ground. And it was easy when the pandemic came, when the COVID-19 pandemic came, to just build up on that. So we could, even though none of the countries are ready for an epidemic, we could see that the countries that have actually gone through Ebola, using that word, that have actually gone through Ebola, were actually had an increase in their scores because, but what I like to feel is that we do not need to have, one pandemic does not need to teach us a lesson to prepare for another pandemic, or one outbreak does not need to teach us a lesson to prepare for another outbreak. So it should not be about we having this framework and institutions after we've had an issue. What steps are the government taking, or are the governments taking to actually put the things that should be in place for us to be ready for things like this? So if I want to follow the conspiracy theorist people who say that the end of the world is coming, and we'll be seeing more plagues and more pandemics and more different things. And these things are actually, if they are going to happen, we need, I'm not saying they will happen, but if they will happen, we need to be actually ready to combat these things. So nobody actually imagined that COVID-19 was going to come. It just came. Nobody was expecting that the Ebola outbreak, when it becomes so rampant in countries, that it was going to come. It just did. And it doesn't look like that's the end. We are not even finished with COVID-19 yet. There are new variants coming in every day, new variants being discovered. And what if the variants discovered tomorrow is worse than the one that we've been battling? And so are we going to now have to starting afresh, now using that as a ladder to prepare, or should we already be prepared to tackle these issues? Next slide, please. So the recommendations from our, I'm just bringing out the recommendations from our research. I think I might be running out of time. So increase in health budgeting. Countries should prioritize allocations to the health sector to accelerate health security and development. So this increase in health budgeting is one of the ways that can actually combat vaccine hesitancy. So we would note that, and if we actually note our history, there has been vaccine hesitancies even before COVID-19. There has been hesitancy to the yellow fever vaccine, different kind of vaccines, and just that the context for the COVID-19 hesitancy was different, but there is still the underlying thing of distrust. And there's the underlying level of distrust of Western countries, because people who propagate these conspiracy theories use a huge chunk of these conspiracy theories is because, oh, it's coming from the white men, it's coming from this, it's coming from that. They want to tackle Black people, they want to do this, they want to do that. So things like this, they also affect it. So increase in our budgeting, then investing in R&D. R&D is research and development. I would like us to actually go through that research because there are a lot of notes that should be noted from that research about research and development. So more needs to be done on leveraging research and investments and supporting capacities for health science research across Africa. It's only when we invest in research that we can actually build capacity to produce local vaccines. And we have public-private partnerships. So because we note that the government cannot be the only ones, they cannot afford to be the only ones producing vaccines, they need private partnerships to actually be able to build and manufacture vaccines. So the private sector should be incentivized to invest and strategically build a local industry. So if you look at the India model actually incentivizes private investment into medicine and pharmaceutical industries. We should find a way that we can replicate that according to context. Then investment in local vaccine production. Africa already has a ready market for vaccines. In the long term, we have the diseases and we have the people. So we have the market. And so economic options should be explored to consider local production. So it's not just doing beggy and now talking about vaccine apartheid and the vaccine equity, vaccine inequality. If we could produce our own vaccines, we won't be talking about vaccine inequality, please. Thank you.
Thanks, Ayo, for a very passionate presentation. I learned a new term, beggy. Thank you for sharing that. Please, could you kindly log in your questions in the question and answer box, and Ayo can respond to them. And I think key to your presentation, Ayo, for me, my main takeaway was the fact that, you know, health allocations, even in the past, they have been minimal. And you said a statement about how the lower the allocation, the increased number of lives being lost, actually, especially looking at the fact that a number of sectors in an economy depend on the health of its citizens, right? And so, you know, health investment definitely needs to increase. And in your recommendations, you also point that you also provide targeted areas like in research and development, and also in sensitizing our communities, especially on the preventative aspect of health system strengthening. Thank you for that. I'm just trying to check if there are any questions as of yet. No questions as of yet for Ayo. The research by CTAP, the one Ayo was making reference to, so very interesting findings. And the links have been shared in the chat. Please do, you know, hop over there and download the report and engage with it. The recommendations are actually applicable to a number of countries, not just those 7 that were looked at in the report. So if there are no questions, I can definitely open it up to the panelists to provide any closing statements, closing remarks. I can start with you, Prof.
Yeah, thank you very much. I liked the last question that someone asked. What can the civil society do? What can we do? I think we can do something, and let's go and do it. Unless, I think COVID came too fast. The civil society was not prepared for it, just like anybody else. And I think what has happened, we have not been able to provide what the guidance that is needed and the accountability that is needed for governments to do the right thing. They may be doing what is best within their capacity right now, but I believe a lot more can be done, including private sector and all these issues around patency laws and all this. So we need to talk more. I believe we have a critical role to play, and we need to use the evidence that we are getting to inform that discussion. And there's a lot of evidence coming up now on things which could be done better. Thank you.
Mm-hmm. Thank you, Prof. Ayo?
Okay, so I have a question in the chat box, in Q&A box. It says, in South Africa, we have that economic stimulus preparedness continues to be understated where the fundamental health and social response is concerned. Please elaborate on your statement about lessons from the pandemic. Surely this will be leveraged. Yes, definitely. So one of our lessons from the research and pandemics showed that Africa is very much unprepared to tackle its health issues, and Africa is very much unprepared to take on another pandemic that would actually hit, if a pandemic actually hits the country the way it hits the other continent, we would actually be in hot soup, using that word. So one of the recommendations we had recommendations for solutions for preparing for a pandemics, and we also had solutions and recommendations for to take on vaccination hesitancy, the stakeholders to consult and how to go about it. So, but one of the things that we can, we can invest in to improve our capacity to tackle pandemics, definitely we'll talk about that, which is increasing our budgets, then having better human resources and education, and that cuts across research and development, investing in our people, maintenance and calibration. So we have the tech effectiveness is very low in Africa. So when we have all these big countries, the cost of manufacturing and producing in Africa is very expensive for them, because sometimes they have to import their experts to come and do some type of work in which they could have actually saved costs if they actually invested it in those countries that had their people. So, and also utilities. Imagine a country like Nigeria that doesn't run a 24-hour power supply. Please, that's a lot of economic loss when you're trying to invest in anything in that country. And there's the national policy and legislation to support vaccine. And also there's a whole talk about, I've forgotten the word to use. I don't want patenting. Yes, patency and all those other issues that we need to critically look into. So I think for a robust, we cannot definitely exhaust a 52-page document because that is a very, very comprehensive research. So please just look into the research and read. It's actually comprehensive and engaging as much as it can. And my final words are, we can continue to actually depend on the West for everything we do. And when we depend on the West and it doesn't come, then we start shouting all the equity, equality, and all the other English that we use, while we are not developing our own capacity to stand on our own. But when it's time to embezzle money and do all those things, we have the capacity to stand on our own to do that. So yeah, I hope another pandemic doesn't come, and I hope this particular pandemic ends soon, so we can all move on with our lives to a large extent. Thank you.
Thanks, Ayo. I think with those words, we are actually at the end of our webinar. Thank you so much, Professor and Ayo, for a very enlightening conversation. You've raised some very important points about some of the blind spots that we may be overlooking as civil society, you know, doing advocacy in the trenches, wherever we are in the continent. And thank you so much for taking time to attend the webinar. And hopefully, please keep a lookout to receive the webinar recording and the research that our panelists made reference to. Thank you. Bye-bye.